happy to start this session. Small group, but nevertheless, I think an important subject. Social deprivation and the consequences on health disparities. We as a European Forum for Primary Care, we have set this topic as a main theme for our 2023 webinars in close collaboration with the Austrian colleagues with which we collaborate a lot in organizing webinars. So we thought, well, it makes sense to have a good introduction of this topic, and we have a great speaker for today, Tessa, who is part of the research collective at the Radboud University, researching health disparities, but also involved in Pharos, which is in fact the Dutch Institute on health disparities and care for migrant and minorities in the society. So I think she is well placed to give us an introduction on this topic. And I'm happy to give you the floor, Tessa. You best start your own sharing, and then my sharing will stop, I think. If you start this or not, I can stop at least, and then you take over.
Mm-hmm. Can you see the screen? Yeah,
well, correct.
Thank you so much for the introduction. I feel that I don't have to introduce myself anymore. My name is Tessa van Loenen, and indeed I'm working at Pharos, which is the Dutch Center of Expertise on Health Disparities. And Pharos tries to contribute to the reduction of avoidable health inequalities in the Netherlands. And we do this by collecting and enriching and sharing knowledge, both scientific knowledge as well as practical knowledge. And we have also a focus on knowledge from the experiences of people in vulnerable situations themselves. And we try to help healthcare providers and policymakers we try to help them and give them tools to reduce health inequalities in their work. Today, I planned to discuss health disparities and the causes that make the problem so persistent. And I wanted to elaborate a little bit more on the role of chronic stress in this. If you have any questions, feel free to ask during the session. You can, we're with a small group, just please, you can raise your hand or put them in the chat. Well, today I wanted to focus on social-economic health disparities. You also have like ethnic health disparities. A lot of the things that I'm telling in this webinar also is applicable for those kind of ethnic health disparities. But when we look at social-economic health disparities, we often compare those with the highest level of education to those with the least level of education. And this is a figure that shows the gap between those two groups on life expectancy. And you can see quite a difference between countries in this graph. For the Netherlands, people with low education have a life expectancy at birth 5 years shorter compared to those with higher education. So basically, they on average die 5 years earlier in the Netherlands. And this difference is everywhere larger for men than for women. And if we look at living in good health, the difference is even 15 years. We can also look at income or wealth, and then the differences are even larger. So recent research in the Netherlands indicates that men from the lowest wealth quintile, so this is kind of a composite measure including both income and wealth, and people in the lowest quintile die on average 9 years earlier, which is, I think, for the Netherlands quite striking gap. And the difference in perceived good health is 25 years for men and 23 years for men. So basically, people in the lowest quintile, income quintiles, experience good health up to an average age of 49 years old. And the wealthiest, the richest men in the Netherlands, on average, feel healthy until 74, which is a huge gap. People with lower income or lower education are more likely to have poor health outcomes, such as they are more likely to suffer a stroke or a heart attack, but also birth outcomes, such as perinatal mortality, is more often with mothers that are from lower education or have a lower income. These are just some examples. There are more worse outcomes in people who have lower income or education. We also see here more chronic conditions are more common in those groups, and we also see that people have an unhealthier lifestyle, such as smoking more. Well, in the picture, it is the difference between lower educated and higher educated. If we look at being overweight or being obese, so 61% of those with lower education are overweight compared to 43% of those with a higher education. Also, during the COVID pandemic, we saw in the Netherlands that groups which are kind of deprived were affected disproportionately. For instance, people with low income were twice as likely to die from a COVID infection. And those with low income and have a migrational background were even more likely to die from COVID. So to summarize, every step on the social ladder makes you more likely to have a worse health, more chronic diseases, earlier death, and having a worse perceived health. So that is called the social gradient of health. And being migrated, they suffer disproportionately. Then, of course, we come to the question, how is this caused and how is this being sustained? Because at least in the Netherlands, the difference aren't getting smaller, they're actually getting larger if we compare data from previous 10, 20 years. Health is determined by a combination of personal characteristics and the circumstances in which people are born, they grow up, they live, they work, etc. And these characteristics are the social determinants of health. And this model of Darwin and Whitehead, it's well known, and it's one of the models that that you can use for the explanation of health disparities. Shows that health disparities, the explanations lie largely with factors outside the health domain. The different layers in this model. So this includes, for instance, unfavorable living and working conditions, but also poverty and debt. They have a direct influence on health. And these circumstances in which we live and work affect your options and lifestyle choices, but also the extent to which people have access to health information or good quality of care, prevention, and other services that you need to stay healthy. So only a small part of the disparities lies within the health services. And that's also what the European Health Equity Status Report shows. They showed what elements people experience in contributing to these inequalities in self-reported health. And then you see the kind of red, the 10% is related to healthcare services, but a very large part of the self-reported health is explained by livelihood security. So having enough money to spend on, for instance, food, etc. But also a large part is related to livelihood security, door living conditions, such as having a good home, a safe home. So only a part is health services, and a large part is related to other things. But the causes of health disparities, it's actually a prolonged living or long-term living in unfavorable and unhealthy condition, living in poverty, poor housing. We also see that people, at least in the Netherlands, in deprived neighborhoods, the air pollution is, for instance, the air quality is poorer than in richer neighborhoods. And also there is insufficient green space. But also make, for instance, that the temperature in those neighborhoods is higher. All things that can cause or influence your health. So besides living for a long term in unhealthy conditions, we also see that care and society is too complicated for a lot of people. The case in the Netherlands, about almost 1/5, 18%, is low literate and have difficulties reading and writing. And about 1/4 of the people in the Netherlands, or the adults in the Netherlands, have limited health literacy. And for those people, it is extra difficult to comply with health advice, with regulations, etc. And understanding is more than being able to read. And this is one example, for instance, how prescription medication is not well understood. So this is an example of how healthcare might be too difficult for people and can cause that that people have worse health because they can't adhere to the advices. So making it more understandable, which is done in this case, and especially making it more concrete, makes it easier to comply. And you can well imagine that this also applies for a lot of other advices on health, but also, for instance, on for those who have debts, regulations on and how where to get advice and how you should manage your debt is also very complicated. And then, of course, besides prolonged living, unhealthy living conditions, and that the healthcare and society is very complicated, you see a lot of other elements that, on top of the first two, create health disparities. And all of these things on the slide causes stress. And we know that stress is bad for health. And I want to elaborate a little bit more on that. These are examples of stressors for people in vulnerable situations. And I'm not talking about, for instance, people who have low incomes or are lower educated. And people often experience an accumulation of these stressors. So on the left side, it's are the stressors that that I already mentioned, and there are long term. So you have for a long time, you're under stress from these stressors. And on the right side, you have kind of short-term events or stressors that add stress. And especially if you're already under stress, that is, the impact might be high. For instance, complicated mail from the taxes of the government, but also from healthcare professionals might give extra stress. This causes health problems. So why is stress, and especially the prolonged stress or chronic stress, so bad? And then we have to take a look at what happens when your body is under stress, especially for an extended period of time. So just being under stress or feeling stressful is not bad at all. And it serves a very useful function when it is relatively short and your body has the time to recover. So in very simplified terms, when encountering a stressor, your adrenal glands produce hormones, and they spread, for instance, cortisol and adrenaline, and they spread across the body. And they ensure an adequate response to the stressor, for instance, by elevating your heart rate or pumping more blood through and oxygen through your spieren, muscles. And that's really nice to have, because, for instance, you can jump away when a car comes fast towards you, or you are able to concentrate when you have to take an exam. But after those events, your body can recover from the stress reaction. But there are also stressors and circumstances to which you are exposed to for a long period of time, and for which you have no control over. For instance, being having debts, and they are, especially those long-term stressors, are physically and emotionally exhausting. And being under prolonged stress makes your system become overloaded. It's called the allostatic overload. So allostatic overload has a direct impact on processes in the body, such as the cardiovascular system, the fat and sugar metabolism, fertility, immune system, and it takes a lot of energy to restore the balance of your body. And this leads to damage to organs, your system, the metabolism, your immune system weakens, etc. But there are also consequences for your mental health. So there's a greater chance of becoming depressed, for instance, or having anxiety symptoms. But also more chance for alcohol use and smoking. And I also like to add that you're not born with a complete working stress system, but the system develops further in your childhood. So being under intense of chronic stress in your childhood determines how your stress system is tuned and how it works. So this makes that the stress earlier in your life has great consequences later in life. Well, here on this slide, on the left-hand side, you see in blue the consequences, the direct the impact on physical health of stress, of prolonged stress. But besides it, stress also affects people's executive abilities, through its impact on the prefrontal cortex. And these executive abilities are skills that you need to help act in a kind of goal-oriented way. So, for instance, to deal with the stressor. And executive abilities are, for instance, concentration or memory, short-term memory, long-term memory, but also planning skills, etc. So on the one hand, we have this chronic stress already directly leading to chronic diseases such as diabetes and cardiovascular diseases. And that are diseases that we know can be controlled by a healthy lifestyle. But that is actually, what is so difficult, because the effect stress has on the prefrontal cortex. That means that people with chronic stress are not well able to make these healthy decisions and resist impulses. So the consequences for daily life, being under stress and having these deprived executive skills, we see that people have difficulties in handling their money well. You see often impulse purchases, so they buy a new television instead while they don't have enough money to pay for groceries, for instance. They are living unhealthier, but we also see that people don't follow doctors' advices or forget to take medication because of their troubles with concentration and memory loss, but also forget appointments, etc. So this all leads to more diseases and less healthy lifestyles. And people enter a kind of vicious cycle or a negative spiral. I think this picture shows that very clearly. Someone with money worries will get a stress reaction. People can no longer think clearly and take and have impulsive behavior increased. Difficulties in addressing the problems they have and make unhealthy choices. They feel even worse. Stress increases, more problems arise, etc., etc., and then the cycle starts again. So we have these unfavorable circumstances that has a direct impact on health. For instance, the living situation, the working situation, poor housing, etc. And all these circumstances also cause a lot of stress, which in their turn leads to even more health risk. But they also lead to being less able to make healthy choices. And on top of that, if we have people with low education, and we have often lower health literacy skills, and being under stress increases also the chance being low health literate, which makes the health risk even higher. So we're talking about a kind of accumulation of problems. Diederik, so far, are there any questions in the chat?
Not in the chat, but maybe if people want to react now already, please do raise your hand or just come in. Otherwise, you continue. But I'm asking already the question to others, especially in connection with the striking figures you mentioned already at the start about your the situation in the Netherlands. To give the responses on the different countries present. So is it striking for you as well to see such figures for the Netherlands? And can you imagine what are the figures in your country, in Slovenia, in Turkey, in Germany? Maybe a first reaction already, Barbara Kegel from Slovenia. Were you expecting such figures for the Dutch situation?
Yes, I think that in Slovenia we have also that problems. I think that it is in all Europe country, almost. I think, I don't know. We have also problem. We also have problem with chronic diseases, with chronic stress, and so on.
But did you expect it for the Netherlands?
No, maybe not, because I think that they are more satisfied with their lives. They have healthy lifestyle more than in Slovenia. I don't expect this from Netherlands. Yes.
André Rochefort from Ireland. Could you add some views on this from your perspective? Is not listening, maybe?
Yes, I'm listening. Yes. A wonderful talk and really inspiring on the broader aspects to contributing to healthcare and health status. I'm curious about the impact of health literacy. And I wonder if there are any countries with data on when we act to improve health literacy. And by health literacy, I mean literacy in terms of numeracy and digital health, as well as reading and writing and understanding. Do we have any evidence that improving health literacy in patients will improve their health behaviours or lifestyles?
Yeah, that's a good question. I'm not sure. At Pharos, where I work, we're not really focusing on increasing health literacy, but making all health information more understandable for people who are low health literate, and that kind of works. That's probably the other way around, so that you make your communication and your advices, etc., that you tailor it to the person in front of you.
Very good. I'm particularly interested, Tessa, actually, in doctors' health because we are highly educated. So we should have, on the basis of data, high education, better healthcare, but many doctors do not follow health education advice and good lifestyle behaviours. So it's a little bit, I'm digging a little bit deeper here, but it's also applicable to the general public, of course.
Yeah, plus they have a lot of stress, I believe, those doctors, certainly nowadays in all these difficult circumstances, isn't it, André?
Yes, of course. So it is complex. You're quite right.
Yeah, yeah. What I'm remembering, we had once at our QET annual conference, so a couple of years ago, we had the presentation of Richard Wilkinson. You should have a look at his presentations. And what I remember very much, Barbara, you were struck by the fact that it's in Holland that terrible. But in fact, he made clear that even in the rich countries, perceiving the inequalities is even more intense sometimes than in lower income countries, as people are seeing themselves really as the poor and the unfortunate and even losers within the society, which is of course increasing stress a lot if you live in such circumstances that you cannot compete within the society. So that's, I think, very much in relation to the talk of Tessa. Yeah. Tessa, maybe you continue, and then we have some more questions at the end.
Yeah, I wanted to talk the last few slides about what can we do to tackle these health disparities, and the key to positively influencing health lies just only partly in the public health domain and largely in other policy domains, such as the poverty, education, housing, work and income, etc. So we need an integrated approach in which there is a collaboration in public and primary healthcare, social care, and local government, but not only within the health domain, but also across the different domains. And the focus should not only lie on lifestyle, but also on the root causes of health inequalities. And health equity in all policies is a term that is widely used. this is also in the Netherlands a hot topic. And health equity in all policies is on the one hand about preventing negative influences on health from decisions in other domains, such as, for instance, building a highway next to a residential area, or industrial areas next to a residential area. We see still also in the Netherlands that the highways or industrial areas are more often placed next to deprived neighborhoods. So it's on the one hand, it is about preventing negative influences from health decisions in other domains, and on the other hand, it's also about see or find measures that contribute to achieving health goals in those other domains. So, for instance, in the Netherlands, the policy domain on work, they had a large integration program for people going back to work, and they integrated healthy lifestyles, for instance, with it. So that other policy, that other domain focused also, incorporated also health. But it will take time and patience to establish such collaboration between different domains. And it is also very important to include the experiences of people's concerned. So what they do, what do they encounter, and what would be a good solution according to them. So citizen participation, and especially the citizens you do not normally talk to, such as the vulnerable groups, is very important also in policy. Another thing that we should do is person-centered care. Person-centered care means that the care is tailored to the person's characteristics, his environment, and the needs. And it puts the person central, not the disease or the complaint. So the focus of the treatment is not necessarily the health problem, but the way patients live and deals with the problems themselves. So the treatment is tailored to the needs, and they take into account the values and preferences of the person, the characteristics of the person, and the context of the person. But it makes demands on the knowledge and the attitude and the skills of the professionals. So professionals kind of need a non-judgmental attitude and inviting attitude that recognize the patient as an equal partner. But you also need the skills to communicate in a tailored way, or being able to identify the social context of such a person, and see if you can reach a joint decision about the health of the patient. So that's the second thing we need to do. This actually is part, I think, of person-centered care, but we need to tailor our communication to the abilities of the patients. So to use understandable communication is very important. So be aware of health literacy. Ask people if they can read and write. There are also checklists or red flag lists that can be used to identify patients with limited health literacy, and we can use simpler language, and we can also use, for instance, information in pictures, and we can use the teach back methods in which you ask the patient or the person next in front of you if they can repeat what you just said. So just to check if what you meant by the advices, for instance, are really understood. And the use of understandable communication is actually comfortable for most people, high or low educated, and even or people with high education also indicate that, for instance, medical language is very difficult to understand, or and they also prefer understandable explanations. For instance, in people also with higher education who are on a lot of stress because they are ill, also decrease in health literacy. So we can, I think it is good to have clear communication, understandable communication for everyone. Another thing that we can do is know about chronic stress and recognize the symptoms of chronic stress. People are often irritable or nervous, arriving late, having concentration problems, etc., etc., sleeping problems, for instance. And it's also important to make people aware what stress does to them. Understanding more about how stress works help people understand that they are not personally failing, but that their problems are largely a result of the difficult circumstances they are in, and that the stress arises as a result of those circumstances, and that their health complaints sometimes also arises from the stress they are feeling. And this realization and the feeling of acknowledgement of the difficult situation provides relief for people in such a situation. And by doing so and make people aware, you normalize what's going on. Help people do something themselves to relieve stress. There are proven activities that are effective in relieving stress. The cortisol levels go down. And these are, for instance, exercise, being outside in green surrounding, mindfulness, listening to music, social contacts, etc. But that is different. What works is different for everyone. And it is therefore also important to connect to people's interest and motivation. And it's also very important to start with small steps, small concrete actions they can take to relieve stress. And then the last thing, we can do a lot of things, but the last thing I want to mention in this presentation is steering for equity. So we need to sometimes have the guts to differentiate. Equal chances for good health and health outcomes requires sometimes unequal treatment. And that is the difference between equality and equity, in which for one intervention for everyone to become healthier, or interventions that are adapted to the needs and capabilities to achieve the most effect. Well, I think that was my last slide. And I think I also have talked way too much. So thank you for your attention. And I'm curious how my story resonates with you, and if there are any more questions.
Well, there is a question, and there is an apology. Kirsten Knight, who is leaving us. Thanks for joining. Well, she has left already, so that doesn't work. From Germany, the question, Franziska Paul. Do we have, some of us, first to Tessa, long-term data regarding chronic stress? Has it increased the last decades or not? And also during the pandemic, do you have any idea, or anybody else?
I don't have data regarding chronic stress. We did in the Netherlands in a few. We are doing a research study in I think 5 deprived areas to chronic stress. It's a PhD doing that. And she did a range of interviews with the same persons, and chronic stress increased for them. But that's more qualitative data, and I'm not sure. I don't have more quantitative data, but I do think it's increased.
Yeah, I believe I've seen some of also related to students very much from the Greek colleagues, that really the stress increased within their student population at a training institute for physiotherapists, occupational therapists, etc. So there is definitely an increase, but maybe have others any data on that? No. Okay. Tessa, I'm very much triggered about the thing of the complexity of healthcare itself, because I think that's something we all together develop further. The specialization goes towards almost unlimited, and it gets more and more complex by this. An example, cancer medication. It's something what the whole cancer treatment, understanding what is possible, etc. It provides even more stress sometimes for patients than simply saying, okay, well, I'm ill and I accept. Well, might be not the real thing, but so I'm interested in how other people think about this. How can we prevent that we make people sicker within the health system through this? Difficult question, maybe. Others from other countries, do you recognize that people are getting confronted with a healthcare system which makes it even more complex for them to respond? André.
Yes, if I might come in there, pardon me, but I'm driving hands-free at the moment, Diedrich, so that's why I'm not
stressful.
At spots, but there we go. Complexity, yeah, it's I'll give you an example. I started my GP training in the late 1980s, and one of my colleagues in the GP training program said when they turned up for their first day as a GP trainee in the practice, they were told all they needed in their emergency bag was a stethoscope and a packet of aspirin. So that's the late 1980s, and how different it is now when we consider the out-of-hours care we provide and all the supplies we have to cover us clinically and medico-legally. So that's just a brief example of how the complexity in care has changed. And patients know this, and families and relatives of patients know this. And I think access to information that is not always of high quality can be confusing for patients. So now, instead of patients coming in for simple checks like they did in the 1980s, people are coming in saying, I would like an MRI scan of my shoulder, or I would like cardiac perfusion MRI. And so complexity of care is difficult for patients, and it's very hard for them to navigate the health system. It's equally difficult for GPs to navigate the health system. So I thought I might just throw that in there.
Yeah, I fully agree on that, and I think, well, tailored care is something what is, of course, you mentioned it, Tessa, very important. But it has also flip side, because, well, what André also just mentioned, people come in with certain expectations, and if you do not respond to these expectations, the stress levels get even higher, including with the family, etc.
Yes, but on the other hand, you can also try to, in your communication, try to explain why these expectations are not met, because
Yeah.
it's not and I think if you have a tailored way of communication that is really understandable for people, then you can explain why these expectations aren't working, and it I think it asks for a different way of training of professionals how to tailor such your communication, and how to how to. I think it's in training of professionals as well.
Yeah. I know Pharos is also being involved in having at least additional training for healthcare professionals. Is this part of your training modules to make professionals more aware of this?
Yes, it is. We have several e-learnings, not in English, all in Dutch, but we have several e-learnings and trainings, and they actually practice with actors on how to address such thing. How to also there are also a lot of maybe cultural beliefs that you need to take into account, or etc. So this is part of the training modules of Pharos. Yes.
That
Any other
sounds
questions?
so excellent.
Yeah.
Yes. Sorry, Diedrich. Tessa, that sounds so good to have special training, which we need. And not just during our specialist training, but as part of our CPD. Let's just take, for example, when the result of an ultrasound comes back and there is an incidental finding. Let's say, for example, an adrenal lesion. And immediately the patient thinks they have cancer. And the temptation for many doctors is to go investigating levels of cortisol and catecholamines and so on. However, we know that the majority of incidentalomas are benign and will never progress to anything. So we need to also work with our hospital colleagues so that they give us clear directions on their results. For example, this finding was found in the adrenal, and it does not need to be ever followed up again. Now that is putting a certainty on clinical prognosis, which is full of uncertainty. But that is the best advice that we have at present, for example, about adrenal incidentalomas. And that just brings up the topic of bringing patients with us in this concept of uncertainty in healthcare outcomes.
Yeah. Well, I cannot agree more. Yeah, wonderful. Well, I think the group is getting very small, although the discussion is good. Camille and Oslem, do you have any other questions, remarks, as you are still present? Please, the floor is yours. The moment of fame is there. Camille? I think you opened your microphone, but I can't hear you.
Hello, can you hear me now?
Yes, correct.
Okay, sorry, I had my headphones on and didn't seem to work. I'm going to put my camera too. So I was a bit an observer today. I'm from the Red Cross EU office based in Brussels, and I was very interested by the topic. So I represent more the technical expert than I'm a technical expert myself, but we are working a lot with health for people with vulnerabilities, and we have a range of services that echo and resonate a bit what I heard today, and we are also like we are developing tools as well to help communication between patients and medical workers. So everything resonated a lot, and no specific question. It was taking information today, but very interesting to have to hear about your approach, and as well I found very interesting the question. I guess it's Andre that brought it, and you replied, Tessa, of do we actually increase health literacy, or do we bring information to the people in a more in an easier format, or more understandable, or more adapted, and yeah, and I think that both needs to work alongside. But I found this very interesting. So thank you very much for the conversation.
Yeah. Well, thank you for this compliment. Were you aware of Pharos, of the existing of Pharos?
No, not at all.
Okay.
And I'm thinking now as well that we have some colleagues in the Netherlands, so Netherlands Red Cross, that work actually on a project. I don't remember the name right now, but I will be able to send the name to you. That is a research project funded by Horizon program, the EU program, working on how public health communication has reached or not the most vulnerable during COVID, and the information that were passed on during COVID. So it can also resonate with what was discussed today, and it's in the Dutch context specifically. But no, I wasn't aware of Pharos, and I spotted the meeting on the health policy platform, and I'm glad I did.
Okay, wonderful. Thanks a lot. I think we have to close. Or Tessa, you want to have a latest remark?
No, it was great. Great to have this presentation today.
Okay, thanks a lot. Andre, take care of driving and watching. Was good to see you again.
Lovely.
And,
thank you so much for bringing this wonderful topic. And Tessa, I hope this is recorded, because I'd love to listen back when I can focus more in detail. You covered so much today. Thank you.
Okay, it is recorded, so we will put it on our YouTube channel and we will inform you about this. Okay, have a good day, and thanks a lot. Bye bye.